By now you should have already watched the depression lecture. Our second mental health lecture is going to focus on anxiety disorders. By the end of this lecture, you should be able to compare and contrast the advantages and disadvantages of our antidepressants, benzodiazepines, and buspirone for patients with anxiety disorders. You should be able to select the most appropriate benzodiazepine for a patient with an anxiety disorder based on their different kinetic profiles, and design a pharmacologic treatment plan for a patient with an anxiety disorder using patient-specific characteristics. For the purpose of this lecture, anxiety disorders is going to refer to generalized anxiety disorder, panic disorder, social anxiety disorder, post-traumatic stress disorder, and obsessive compulsive disorder. Of note, PTSD and OCD are no longer categorized as anxiety disorders in DSM-5. The treatment is still similar for these disorders, so we're going to cover them in anxiety disorders. This chart provides a summary of our first and second line treatment options for anxiety disorders. You'll also see a list of alternative agents that may be used further down the line or for very specific purposes with certain anxiety disorders. For example, use of prazosin to help treat nightmares associated with PTSD. The first and second line treatment options will really vary depending on the guidelines that you're looking at or the resource that you're using. So this is just meant to serve as a general guide. You may see some differences in practice. In general, our first line treatment options are our SSRIs and SNRIs, and we already covered these in the depression lecture. So you already are familiar with these and know all the information and can now apply it to anxiety disorders. In terms of our second line treatment options, we're just going to focus on buspirone and the benzodiazepines today. Many of these other agents you'll cover in other topic areas. For example, pregabalin and gabapentin should be covered in epilepsy or perhaps pain. The tricyclic antidepressants aren't used as much for depression or anxiety anymore and are more often used for pain syndrome. So you should learn about these agents in other areas. We're just going to spend a couple minutes talking about some unique considerations when using antidepressants for treatment of anxiety disorders. I already mentioned that our SSRIs and SNRIs are first-line treatments for all anxiety disorders. And then there is some emerging evidence for use of mirtazapine. This agent is being studied more for anxiety and being used more in the clinical setting, but it still does not have the data that our SSRIs and SNRIs do. There's really limited evidence for using bupropion for anxiety disorders because it's typically too activating for most patients, especially if they have something like PTSD. And then our TCAs and our MAOIs, so the tricyclic antidepressants and monoamine oxidase inhibitors, are reserved for later in treatment due to safety and tolerability concerns. One kind of exception to this is that imipramine and clomipramine are still used fairly often for obsessive compulsive disorder, especially if a patient has tried and failed a couple SSRIs or SNRIs. There are some other special considerations for anxiety disorders. We talked about a lot of adverse effects when we talked about these medications in the depression lecture. There's one of them that I kind of want to carry forward and highlight again, and that's that these medications can transiently increase anxiety. So it's really important to educate patients and let them know that they may initially feel an increase in anxiety for the first few days, but then this should go away and get better. In terms of dosing, you want to start with lower doses to help minimize initial increases in anxiety and then slowly titrate the dose. We'll typically start with about half the typical dose used for depression because this can help minimize the initial anxiety and is particularly helpful for patients with panic disorder. Maximum doses of SSRIs are typically needed for obsessive compulsive disorder due to poor response with average doses used for other disorders. And then it's important to note that our anxiety symptoms may initially respond faster to the antidepressant than depression symptoms do. So we'll see this medication start working within about 2 to 4 weeks, but the maximum effect can actually take longer due to that slow dose titration. There are many advantages to using the SSRIs and SNRIs for anxiety disorder. They're tolerated well and have really good safety profiles compared to a lot of our other medications. We also have strong efficacy data. They are effective for cognitive symptoms, and that would be something like apprehension and worry, and also effective for patients who have a comorbid depression diagnosis, which is nice. And then these medications, compared to others, lack abuse and dependence potential. Some of the disadvantages are that even though symptoms respond faster for anxiety than they do with depression, we still have a delayed onset of effect, and you can see that transient increase in anxiety when they're started or when doses are increased. Also, patients can have withdrawal symptoms if these medications are abruptly stopped. We're now going to spend quite a bit of time talking about the benzodiazepines, and listed here are the agents that have FDA approved indications for anxiety disorders. There are other benzodiazepines that have indications for sleep disorders. It's important to note that all benzodiazepines possess anxiolytic properties, but just these agents have the FDA approval. Benzodiazepines are primarily used as bridge therapy in anxiety, and that's because they provide very rapid relief of anxiety symptoms, so we can use them while we're waiting for the antidepressant to take effect. But we're not going to use them in every patient with anxiety. We'll typically reserve them for patients with very severe anxiety symptoms, if they have presence of triggers or ongoing life stressors. We'll ideally want to limit their duration of use to about 2 to 4 weeks while we're waiting for that antidepressant to take effect. We should then taper and discontinue them. There's much less evidence for using them as maintenance therapy in anxiety disorders, but it may be appropriate for patients who have treatment-resistant anxiety. Clinically speaking, you will see patients who are on benzodiazepines for long periods of time and do quite well with them for anxiety disorders. So while that's not ideal, you will see that in clinical practice. We do have evidence supporting use of benzodiazepines in generalized anxiety disorder, panic disorder, and social anxiety disorder. It is effective for the somatic and sort of autonomic symptoms, but not for apprehension or worry, so those cognitive symptoms. It is also recommended that we do not use benzodiazepines for PTSD or OCD. They're not effective and can actually worsen these anxiety disorders. Benzodiazepines work by binding the GABA A receptor. GABA is our major inhibitory neurotransmitter in our body, so these medications essentially enhance the inhibitory effects of GABA. Our benzodiazepines are equally efficacious, so we're really going to choose an agent based on its kinetic profile. There's a lot of information on this slide, so I'm going to try to draw your attention to what I think is most important from a clinical perspective. These agents do differ in regard to their half-life, so how long they'll stay around in the body, and you definitely don't have to have any of those numbers memorized, but it's important to note that agents like diazepam have a very long half-life, and that's typically because they have an active metabolite. And you'll notice that the agents that have active metabolites do have the longer half-lives. They are also metabolized a little bit different. So lorazepam and oxazepam go through glucuronide conjugation, while all the other benzodiazepines listed are metabolized by CYP enzymes or undergo hepatic oxidation. And this is important because hepatic oxidation can be impaired by liver disease, it can be impaired in patients who are elderly, or if they're taking medications that inhibit this process. While with glucuronide conjugation, this does not decline with age and makes lorazepam and oxazepam better options for our elderly patients. Another thing to note is the rate of onset after oral administration. And you'll notice that diazepam has a very long half-life, but then also has a very fast rate of onset. And that is because diazepam is very lipophilic, so it's going to rapidly absorb in our bodies and quickly distribute into the CNS. This results in a rapid and intense relief of anxiety symptoms, as well as sort of a euphoric rush. However, it's also more quickly redistributed out of the brain, leading to a shorter clinical duration of action. So diazepam has a long half-life, but a shorter period of clinical effects. Comparatively, lorazepam and oxazepam are less lipophilic and have a slower absorption and onset of action. So an important thing to take away from this is that, again, in our elderly patients, we're going to choose agents like lorazepam and oxazepam because they do not have active metabolites, they're less likely to accumulate in the body, their metabolism doesn't depend on this hepatic oxidation, and they're not agents that'll rapidly redistribute out of the brain. There are some drug interactions to be aware of with our benzodiazepines, and these interactions can be pharmacodynamic or pharmacokinetic. With our pharmacodynamic interactions, we're worried about additive side effects, and we're specifically worried about respiratory depression or CNS depressant effects. So we really don't want patients combining these medications with alcohol, and ideally not opioid medications. You will see patients on antipsychotics and benzodiazepines. But again, ideally, we want to try to avoid this to help avoid those additive side effects. In terms of our kinetic interactions, we have to be careful with other medications that can induce or inhibit CYP enzymes, specifically CYP3A4 or 2C19, which metabolize a lot of our benzodiazepines. Listed here are some examples of medications that can induce those CYP enzymes and examples of medications that can inhibit those CYP enzymes. With medications that inhibit CYP enzymes, you'll get higher concentrations of benzodiazepines in the bloodstream and potentially more side effects. This chart provides you with some information on dosing. You'll see usual dose ranges for the various benzodiazepines, our maximum recommended doses for geriatric patients, and approximate equivalent doses in case you need to switch from one benzodiazepine to another. You're not required to memorize the dosing by any means, but what's probably more important to know is that you should initiate these medications at very low doses and then titrate over several weeks until you reach a therapeutic dose. It's also important to use scheduled dosing regimens. So when using these medications for anxiety, they should ideally not be given on an as-needed basis. We really only use as-needed dosing for treatment of short-term distress like air travel or patients that have dental phobia. Otherwise, these medications should be given on a scheduled basis for anxiety. It's important to educate patients to not abruptly stop their benzodiazepines because this can lead to withdrawal symptoms, and benzodiazepine withdrawal can be potentially life-threatening. So this medication really needs to be tapered over several days to weeks, and the duration of the taper is going to depend on how long they've been on the medication, and we'll show an example of that on the next slide. More common symptoms associated with benzodiazepine withdrawal are just kind of rebound anxiety, irritability, tremor, and maybe some aches and pains. On the more rare end of the spectrum, you'll see things like confusion, delirium, potentially seizures, or, as I mentioned, death. The onset of withdrawal symptoms can occur 1 to 2 days after stopping an agent with a short half-life, or up to 4 to 7 days if they're abruptly stopping an agent with a longer half-life. Unfortunately, there is no standard approach to tapering a benzodiazepine. This tends to be really provider or clinician specific. One approach is to reduce the dose by 25% until 50% of the dose is remaining. You can then reduce the dose by 1/8 every 4 to 7 days, but this does get a little confusing and perhaps time intensive. And then your duration of taper really depends on how long the patient's been on the therapy, and then listed in this chart is the recommended duration of taper according to how long they've been taking the benzodiazepine. Clinically speaking, you may see clinicians do the taper at a much faster rate just to help get the patient off of the benzodiazepine, but these are the recommended durations to help minimize that withdrawal. Our benzodiazepines are associated with several adverse effects, and many of them are related to the CNS depressant effects. So this is where you'll see things like drowsiness and sedation. And sedation is our most common side effect of our benzodiazepines. In regards to psychomotor impairment, you'll see things like increased risk of falls, confusion, and memory problems. And then ataxia is a lack of coordination of muscle movements. You'll also see respiratory depression, so we want to avoid these medications in patients with sleep apnea or severe respiratory disease like COPD. They can, for this reason, be problematic when combined with our narcotic pain relievers and alcohol. We can also see anterograde amnesia, which is forgetting things that occur after the drug is ingested. You should note that these medications are Schedule IV controlled substances, and this reflects their potential for abuse and dependence. And any benzodiazepine can be abused, or patients can become dependent on it. If a patient truly has an anxiety disorder, they tend to do well on the same dose for a long period of time. So keep this in mind, as opposed to when we talk to sleep disorders where patients tend to need escalating doses. We don't see that as much in anxiety disorders, where patients tend to respond well and do pretty well on the same dose over time. You should try to avoid these agents in patients with a history of substance use disorders just because of their potential for abuse. And agents with a quicker onset of action, like diazepam, are more likely to be abused because of that euphoric feeling that they cause. We really want to try to avoid using benzodiazepines in our elderly patient population, and that's because they are more sensitive to the adverse effects, and tolerance to these adverse effects can occur more slowly. Our elderly patients can be at increased risk for falls due to balance impairment, sedation, and the muscle relaxant effects, and they also cause memory problems. These medications are on the Beers list of potentially inappropriate medications for elderly patients. If you are going to use an agent in an elderly patient, lorazepam and oxazepam are preferred because of their kinetic profiles. These medications can also cause paradoxical disinhibition in our elderly patients, which is actually an increase in anxiety, irritability, or agitation. And then elderly patients are usually treated with about half the typical dose, and it's titrated more slowly due to those adverse effects.
The benzodiazepines have been associated with causing cleft palate when taken during the first trimester. So we want to avoid using them during the first trimester whenever possible. They are also associated with causing withdrawal symptoms in the baby, low birth weight, and premature birth. In general, we want to try avoiding use of benzodiazepines during pregnancy. If they must be used, it is better to use them in the second or third trimester, where there isn't as much risk for cleft palate, and they should only be used at the lowest possible dose and for the shortest duration possible. They are excreted in breast milk, so it is recommended to avoid using them during lactation. In regard to our pediatric patient population, safety and efficacy have not been established, and we typically try to avoid use of benzodiazepines.
The benzodiazepines are equally efficacious, so selection of an agent is really going to depend on that kinetic profile as well as patient-specific factors like age. And we already talked through a lot of these issues, so I won't rehash them, but just keep in mind these are the things you can use to help pick one agent over another. Some of them also come in different dosage forms, and so some are available in like an extended release formulation versus quick dissolving or sublingual formulations. One of the biggest advantages of the benzodiazepines is their rapid onset and relief of anxiety symptoms, and it does make them good use for bridge therapy in certain patients. They're also not likely to worsen anxiety, and some of them are available in multiple different dosage forms. However, they are associated with many disadvantages. Just like our antidepressants, they can cause withdrawal symptoms if they're abruptly discontinued, and they're not effective for cognitive symptoms associated with anxiety, nor do they have an antidepressant effect. There is potential for abuse and dependence, so this can make them problematic for use in patients with substance use disorders or in patients who are drinking alcohol. They do have a problematic adverse effect profile, so we need to be very cautious about using them in our special patient populations, as well as provide a lot of education when we are prescribing them. I already mentioned they're dangerous if combined with alcohol and even opioids, and there is potential for overdose. We do have an antidote if patients overdose on them, but that means that they need to seek help for that. They're not ideal for our geriatric patients, our pediatric patients, or women who are pregnant. And then they do have complex kinetic considerations, and this can be difficult for a lot of providers to fully comprehend. Finally, they're not recommended for PTSD and OCD, so you shouldn't use them in patients with those types of disorders. I'm just going to spend a little time talking about buspirone. I wanted to touch on it because it's really only used for anxiety disorders, and it's typically used second line for generalized anxiety disorder. Like our antidepressants, this medication is also effective for things like apprehension and worry, which is one nice feature. It works by being a partial agonist at serotonin 1A receptors, and this eventually reduces the firing of serotonin neurons. In terms of kinetics, it's more simple than the benzodiazepines. You should note that it's metabolized by CYP3A4, so drugs that can inhibit CYP3A4 can increase buspirone levels. The initial effects of buspirone can be observed within the first 2 weeks, but 4 weeks may be needed for optimal results, so this also has a delayed onset of action. In terms of adverse effects, it's typically tolerated pretty well. Most often we'll see things like dizziness, headaches, nausea, and we can also see some initial nervousness like we do with our antidepressants. Buspirone is tolerated well and has a good safety profile just like our antidepressants, and is also effective for cognitive symptoms. Another nice feature is that it lacks abuse independence potential and is typically non-sedating. There may be some patients who initially experience drowsiness or fatigue when the medication is initiated, but for the most part this is non-sedating, which is a big contrast from our benzodiazepines and some of our antidepressants. In terms of disadvantages, we once again have this delayed onset of effect that we see with our antidepressants. They can initially increase anxiety before they help reduce it. This does not really have an antidepressant effect, so that's one disadvantage compared to our antidepressants. It also has to be dosed more frequently, so it's 2 to 3 times daily, which can cause issues with adherence. And then it's not effective for all anxiety disorders. We most often see it used for generalized anxiety disorder. It also has mixed evidence, so its evidence is not as strong as our SSRIs or SNRIs. To summarize this presentation, our SSRIs and SNRIs are first-line treatment for all anxiety disorders but can take 8 to 12 weeks to take full effect. This creates a role for benzodiazepines, which can be used as bridge therapy while we wait for antidepressants to take effect for certain patients. Our benzodiazepines are equally efficacious, so selection of the agent is going to depend on the kinetics of the medications as well as patient-specific factors. We want to avoid using the benzodiazepines in the elderly, but if we are going to use them, we'll want to use lorazepam and oxazepam. Lorazepam and oxazepam would also be preferred in patients with liver disease because they don't require that hepatic oxidation. We need to use caution in patients with a history of substance use disorders because of their potential for abuse and dependence, and then they are not recommended for patients with PTSD or OCD. Buspirone is typically a second-line treatment for generalized anxiety disorder, but it has a good safety and tolerability profile and is a great option if patients aren't fully responding to an SSRI or SNRI.